Namaste बिटिया, हमेशा खुश रहो बिटिया. A very good morning to you all. Myself, JVM Dr. Ravi Jain, Assistant Professor, Department of Practice of Medicine, and Faculty of Homeopathic Science at JAYOTI VIDYAPEETH Women's University, Jaipur. In this series of lectures, we have been discussing about the various diseases related to the thyroid gland. We have discussed about hypothyroidism, we have discussed about thyrotoxicosis, we have discussed about the multinodular goiter, we have discussed about goiter, multinodular goiter, and many more topics in the previous sessions. Today, we are going to discuss about another important topic that is known as solitary nodule. So, what is a solitary nodule? What are the different causes of solitary nodules? How to diagnose and do the treatment of the solitary nodule that we are going to discuss today. Apart from the solitary nodule, we are also going to discuss about the thyroid crisis, its etiopathogenesis and management. And also, we are going to discuss about another important topic that is important for the point of view of short note, that is Myxedema and Cretinism. All these things we are going to discuss in today's lecture. So let's start with today's lecture of solitary nodule. What is solitary nodule? Solitary nodule, it is resulting from the toxic adenoma. And toxic adenoma is basically an autonomously functioning thyroid nodule. What are the different causes of toxic adenoma? Toxic adenoma is caused due to the mutations that stimulate the TSHR signaling pathway. So toxic adenoma is resulting from the mutation that stimulates the TSHR signaling pathway. Now, what is TSHR? TSHR is basically the thyrotropin receptor. Now, what are the clinical features of toxic adenoma? In the clinical features of toxic adenoma, thyrotoxicosis is usually mild. So whenever a patient is coming to us with the case of toxic adenoma, then we are going to see that thyrotoxicosis, it is mild. The disorder is suggested by subnormal level of the TSH. So there is mild thyrotoxicosis and it is suggested by the subnormal TSH levels. The presence of thyroid nodule, which is generally large enough to be palpable, and there is absence of clinical features that is suggestive of the Graves' disease and the other causes of thyrotoxicosis. So in case of toxic adenoma, there is autonomously functioning thyroid nodule that is caused due to the mutation that stimulate the TSHR signaling pathway. In the clinical features, we will see that thyrotoxicosis, it is usually mild in such cases, and the disorder is suggested by subnormal level of the TSH. The presence of the thyroid nodule, which is generally large enough to be palpable. So we will have a solitary nodule, a thyroid nodule that is large enough to be palpable. There is absence of the clinical features that is suggestive of the Graves' disease and the other causes of thyrotoxicosis. So although this is toxic adenoma, means there is excessive production of the thyroid hormone, but there are the features of Graves' disease and the other causes of thyrotoxicosis are usually absent. Now, how can we diagnose a case of solitary nodule and how to manage the case? For the diagnosis, we can go for the thyroid scan. That is, we can do the thyroid scanning and it will provide us a definitive diagnostic test for the diagnosis of the solitary nodule. So we can go for thyroid scan and it will demonstrate the focal uptake in the hyperfunctioning nodule. So the diagnosis can be done by the thyroid scan and it will provide a definitive diagnostic test and it will be demonstrating focal uptake in the hyperfunctioning nodule and diminished uptake in the remainder of the gland. So in the thyroid gland, the most active part will be seen as having hyperfunctioning nodule and it will be having greater uptake of the substrate and the remainder part will be having a normal or the diminished uptake of the substrate for the production of the thyroid hormone. Now, how to treat a case of the solitary nodule? The treatment of solitary nodule consists of the radioiodine ablation by iodine 131. We can also prescribe antithyroid drugs to the patients and the beta blockers that can normalize the thyroid function. and ultrasounded guided repeated ethanol injections and percutaneous radiofrequency thermal ablation to ablate the hyperfunctioning nodules. So in the treatment of solitary nodule, we can go for the radioiodine ablation, but iodine 131. Antithyroid drugs and beta blockers can be given, and ultrasounded guided repeated ethanol injections can be applied to the patient, and percutaneous radiofrequency thermal ablation to ablate the hyperfunctioning nodule can be done. So this was all about the solitary nodule. Now we are going to discuss about the thyroid crisis. What is thyroid crisis, how it is precipitated, and how to manage a case of thyroid crisis. So in this lecture, we are going to discuss about various small topics that can be asked in the short note during the examination. So thyroid crisis, what is thyroid crisis? This we are going to discuss now. In the thyroid crisis, it is a rare and it presents as a life-threatening exacerbation of hyperthyroidism. So thyroid crisis can be seen with the hyperthyroidism. So it is seen with the hyperthyroidism and it is accompanied by the fever. There can be fever in thyroid crisis. There will be delirium. There will be seizures, coma, vomiting, diarrhea, and jaundice. So in the thyroid crisis, it is usually accompanied by the hyperthyroidism and it is accompanied by fever. In the thyroid crisis, there will be fever, there will be delirium, seizures, coma, vomiting, diarrhea, and jaundice. And even with the treatment, the mortality rate is high as around 30% due to the cardiac failure, arrhythmias, and hyperthermia. So treatment, first of all, diagnosis and the treatment of thyroid crisis is very important because it can lead to a very high mortality rate. So thyroid crisis, it is presenting as a life-threatening exacerbation of the hyperthyroidism. So this is a life-threatening condition. If it is associated with hyperthyroidism, then it can cause the death of a lot of people. And it is accompanied by fever. There will be delirium, seizures, coma, vomiting, diarrhea, and jaundice. And the death will be due to the cardiac failure, arrhythmia, and hypothermia. Now, how the thyroid crisis is precipitated? So thyroid crisis is precipitated by the acute illness, by surgery, or radioiodine treatment. So there are three factors that are responsible for the precipitation of the thyroid crisis. One is the acute illness, next is the surgery, and the third one is the radioiodine treatment. In the acute illness, it can be precipitated by the stroke. There can be infections, trauma, and diabetic ketoacidosis. So it is precipitated in the acute attack by the stroke, infections, trauma, and diabetic ketoacidosis with previously unrecognized on or inadequately treated thyrotoxicosis. So thyroid crisis can also be precipitated by surgery. Surgery that is developed shortly. It is thyroid crisis can be developed shortly after subtotal thyroidectomy. So it can be precipitated after acute illness, different illnesses like stroke, infection, trauma, and diabetic ketoacidosis that are precipitated on the inadequately or unrecognized cases of thyrotoxicosis. It can be precipitated after surgery and surgery for the after subtotal thyroidectomy, or it can be also precipitated by the radioiodine treatment. In case of partially treated or untreated hyperthyroidism with iodine 131 therapy, when the acute irradiation damage may lead to the transient rise in the serum thyroid hormone levels. So this is basically a thyroid crisis is a life-threatening condition that is occurring with the hyperthyroidism. Now, how to manage such case? Management of the case of thyroid crisis is done by the following ways. Number one, intensive monitoring and supportive care has to be done. Second is the identification and treatment of the precipitating cause. So we can manage it by intensive monitoring and supportive care. We can check it by identification and treatment of the precipitating cause. Third is the to measure the reduced thyroid hormone synthesis. Now, reduced thyroid hormone synthesis includes rehydration, broad spectrum antibiotic, propranolol, and sodium iodate that will restore serum T3 levels to the normal in 48 to 72 hours. And oral carbamazole that inhibit the synthesis of new thyroid hormone. So in the management of thyroid crisis, we can do following things: intensive monitoring and supportive care. Next is identification and treatment of the precipitating cause. Third is the measurement, the various measures to reduce the thyroid hormone synthesis. The various measures to reduce the thyroid hormone synthesis includes rehydration, broad spectrum antibiotics, propranolol, and sodium iodate. So this was all about the thyroid crisis. Now we are going to discuss about the myxedema. What is myxedema? Myxedema is associated with primary hypothyroidism. So thyroid crisis was associated with hyperthyroidism, and myxedema is associated with the hypothyroidism. So primary hypothyroidism in the juveniles and adult will lead to myxedema. So if there is hypothyroidism since birth, that is the primary hypothyroidism in the juveniles and adults, this will lead to myxedema. Now, what are the clinical features of myxedema that can present in the patient? The clinical feature will depend upon the degree of the impairment of the thyroid function and its duration. So this we have studied at many places, that the clinical features will be based on the degree of thyroid dysfunction and the duration for which the symptoms are present in the individual. The onset will be insidious and often unnoticed. So there will be insidious onset, and the clinical features will not be will remain unnoticed. There will be slow activities with lethargy, somnolence, constipation, and generalized disinterestedness. So we will have the general features of hypothyroidism that are going to develop slowly and steadily. There will be slowness of the activities. There will be lethargy. The patient will be lethargy and tired easily. There will be somnolence. Constipation and generalized disinterestedness can be seen. The patient can have weight gain without actual increase in the appetite. There can be hair fall, puffiness, and thickening of the skin. So patient can complain with the slow activities, lethargy, somnolence, constipation, generalized disinterestedness, weight gain, hair fall, puffiness, and thickness of the skin. Now, what are the various lab investigations that could be done in case of myxedema? So in case of myxedema, we can check for T3 and T4 level, that will be low, and TSH level will be high. Iodine 131 uptake in the thyroid gland will be low, and antibodies TPO, that is thyroxine peroxidase, are usually high. The serum cholesterol levels raises above 300 mg per dl, and the BMR is usually low. So in the investigations, we can check for T3, T4 level, which is low. TSH will be high. Iodine 131 uptake is usually low. Antibodies TPO are high. Serum cholesterol level is raised above 300 mg per dl, and the BMR is low. Now, what is the course and prognosis of myxedema? Myxedema, it is a slow progressive with fluctuations seen in the thyroid functions. So in the myxedema, there is a slow progressive disease, and there are functioning of the fluctuations in the thyroid function test can be seen. There is delay in the if there is any delay in instituting the treatment in children, then it will result into the permanent retardation of the mental facilities of a child. So the treatment has to be done at a very early stage, otherwise there will be permanent retardation of the mental facilities will take place. Now, how to treat such case? The treatment is very easy in case of myxedema, that is replacement with the thyroid hormone, that is levothyroxine has to be given throughout the life. There is another condition that is known as myxedema coma. Now, it is also related with myxedema, and in the myxedema, when the coma is resulting from the combination of factors like heart failure, cerebral ischemia, hypothermia, and hypothyroidism. So with myxedema, if there is coma that is resulting from the combination of factors like heart failure, cerebral ischemia, hypothermia, and hypothyroidism will lead to the development of the myxedema coma. How to treat a case of myxedema coma? For the treatment of myxedema coma, because it is associated with heart failure, cerebral ischemia, hypothermia, and hypothyroidism, hospital admission is essential with the administration of triiodothyronine intravenous 20 microgram every 4 hourly. Hydrocortisone can be given to prevent hypoadrenal crisis, and dexamethasone, that is a steroid, it is a treatment of choice. So this was about the myxedema. Now we will come to the cretinism. Cretinism is another important disease that is usually asked in the short note. So what is cretinism? Cretinism is resulting from the hypofunctioning of the thyroid gland from birth. So cretinism is resulting from the hypofunctioning of the thyroid gland, that is resulting from the birth of a child. The iodine deficiency, it is occurring in the endemic goiter belts. So cretinism we are going to see in the endemic goiter belts, where the iodine deficiency is very prominent. The babies born to hypothyroid mothers or those who are taking antithyroid drugs during the pregnancy are more prone for development of the cretinism. So cretinism is resulting from the hypofunctioning of the thyroid gland at birth. There is iodine deficiency that is occurring in the endemic goiter belts. The babies are born with the hypothyroid mothers or taking antithyroid drugs during pregnancy. Now, what are the clinical features of a cretinism child? So, in the clinical features, the baby is usually lethargic at birth. The growth is retarded. And there is large protruding tongue with broad flat nose and widely set eyes. So cretin baby, it is many times asked in the examination about the cretinism, especially in the short note. So the clinical features of the baby, it includes the lethargic baby, that is the baby is very much tired. The growth is retarded and there is large protruding tongue. The broad flat nose is there and the eyes are widely set. In the clinical features of the baby will have sparse hair and there will be dry skin. So the baby can have sparse hair, dry skin. There will be protuberant abdomen. So the abdomen will be protuberant in such children with umbilical hernia, with a tendency for development of umbilical hernia. There will be abnormal persistence of the physiological jaundice. So in such babies, physiological jaundice will be persistent for a quite more amount of time. The voice will be croaky and the patient will have constipation. There will be somnolence and feeding problems. So in the cretinism child, there will be sparse hair, dryness of the skin, protuberant abdomen and umbilical hernia with abnormal persistence of physiological jaundice. There is croaky voice, constipation, somnolence and feeding problems. As the baby is growing older, there will be retardation of the growth and the milestone will become, there will be delayed milestones. The neurological abnormalities will be seen in such children with deafness, spastic limbs and coma. The ossification will be delayed. So as the baby is growing older in case of cretinism, there will be retardation in the growth as well as mental retardation. There will be certain neurological abnormalities like deafness, spastic limbs and coma, and the ossification will be delayed. Now, how to treat a case of cretinism? The treatment is again very simple. The replacement of the thyroid hormone with a dose of 10 to 15 microgram per kg body weight and routine estimation of T3, T4 and TSH has to be done. So this completes the thyroid hormone, the thyroid gland diseases today. And in the next lecture, we are going to start with a new system with endocrinology. So this was all for today. This session is powered by Digital Version 2.0, JAYOTI VIDYAPEETH Women's University. I hope you have understood the session properly. If you have any query, please mention in the comment box and I'll try to resolve it. So this was all for today. I would suggest you to go through the e-notes that I've uploaded on the portal. And for any query, you can contact me directly. So this was all for today. Thank you very much. We will be meeting in the next lecture tomorrow. Thank you.